how do you prefer? Do you prefer that at first you say something, or do you want someone, a resident, to present the study, or what do you prefer?
I'm happy. I'll make the assumption that everyone has discussed the study because you all asked a lot of very good questions. So I thought I might just quickly go over some little bits. It's probably easier if I present and then we take questions, maybe.
Perfect. Okay.
Or I'll just stop periodically in case you want to ask things as we go.
Yes. Okay. So thank you very much for being here. And Simon Brown is a professor at University of Western Australia, but now he has returned in Tasmania, and he will show us some part of his life. And he's the author of this study about pneumothorax that I think is very, very interesting and important. So thank you very much for being here, Simon. Thank you.
Thank you for the invitation, Giorgio. And I will do my best to speak slowly and carefully and not speak like a crazy Tasmanian. Okay, so my life is a little bit confusing if you do a PubMed search. So I thought I might just quickly give an overview of what I've done over the years and how I got involved in this study. So I'm originally an emergency physician. So the qualifications that I've accumulated initially were Bachelor of Medical Science, Bachelor of Medicine, Bachelor of Surgery, Diploma of Anaesthetics, and then a Fellowship of the Australasian College for Emergency Medicine. And I started my professional career with a focus, so back in 1988 is when I graduated from medicine, then spent about 6 or 7 years doing that training with a focus on critical care and retrieval medicine. And then, for reasons I still don't quite understand, I got sidetracked into a PhD in clinical immunology. Started doing work on snake and spider envenoming. We did several multi-center randomized controlled trials, focusing first on venom immunotherapy and anaphylaxis, then giving fresh frozen plasma for venom-induced consumption coagulopathy, which we see in Australian snake bites. That's quite a severe defibrillation syndrome that Australian snakes cause. And we also looked at how the use of antivenom for lactrodectism. So I think you have those in Italy as well. What we call the redback spider, you call the black widow. And we did 2 trials. We compared intramuscular versus intravenous antivenom, and then we did a trial of antivenom versus placebo. And they're all very fascinating studies. And then I ended up back doing an academic job as a professor at Royal Perth Hospital in Western Australia. And although I've left and come back to Tassie, I still maintain a link as a clinical professor there with some of the sort of research collaborations that we've developed over the years. Over there, we did some anaphylaxis and sepsis research and started looking at multi-center clinical trials. And we've done a couple of pneumothorax studies, an observational study, and then the randomized controlled trial we'll talk about today. And then came back to Tasmania. Mainly for family reasons, time for a change, doing some clinical work, which I can't spell. I've spelt it clinical work. I always spell it that way, and I'm not too sure why. But anyway, I was recruited to set up a new aeromedical unit, a helicopter emergency medical service, and that became, I suppose, the first time we've had a pre-hospital and retrieval medicine specialty in Tasmania. And we set up a new unit, the Critical Care and Retrieval Unit, or CCR, for the state. And there's a link there that you can follow if you want to know more about that. And I've sent you a copy of their presentation, Giorgio. So my career took a full circle, ending up like a tornado going up rather than a whirlpool going down. And I would never have thought that I'd be winching from helicopters at the age of 57 or falling off my mountain bike and busting my shoulder. So I may have to give up soon, I think, and have a slightly more relaxed lifestyle. It's good though. I mean, we get to fly all around Tasmania. You can see here a trip we did recently where we go right across some of the best natural wilderness, World Heritage Area, flying over the mountains and lakes and coming around with an injured diver at sea level all the way around the west coast of Tasmania. There are no towns, no roads. This is just absolutely pristine wilderness. Landing on a helipad, perched on the side of a mountain with a great view. And this is the video of the last trip that we did. So you're coming around the side of Tasmania at sea level with a diver, seeing some of the most amazing wilderness, beaches, crappie outcrops. So Tasmania is a great place to do aeromedical work. And I'm just boasting a bit here. So I don't just do clinical trials. I can't get, there we go. And of course, we get to go fishing too. So some lovely lakes. For those of you that do trout fishing, this is a little trout fly, which was then used to catch a few trout on that beautiful lake. So that's why I came back to Tasmania. And with that, I can talk about the study that we did before I came back to Tasmania. Would you like to know anything more about my career, Giorgio? Or does that sound sufficiently interesting for people that would like to come to Tasmania? Okay. I'm not very good at an evil monologue. Do you guys know what an evil monologue is, Giorgio?
Can you repeat?
It's a joke. If you look at some of the spy movies or the superhero movies, the villain just talks on and on and on about his plans to take over the world. It's a monologue, one person talking, and it's evil, the evil monologue. When I'm giving a talk over the internet where you can't see people's faces, because all I can see is little dots on the screen.
Yes.
It feels like I'm giving an evil monologue.
Yes.
So feel free to put hand. If anyone wants to actually ask a question, just put a little hand up, and I think I can see it on this. So,
do you prefer that someone open the camera?
No, it's okay. But if anyone has a question, feel free to put a hand up, and then I can ask you, Giorgio, if you want to take a bit of a pause. So when we started doing this study, so far, oh God, it'd be 10 years ago now, the treatment guidelines were for spontaneous pneumothorax really depended upon whether it was a secondary versus a primary spontaneous pneumothorax. So a secondary pneumothorax with underlying lung disease would normally have a tube put in. And then for a spontaneous pneumothorax, the treatment used to depend on size of the pneumothorax and symptoms. So now, and this is what we call a spoiler alert. So I'm kind of telling you what I'm going to tell you before I tell you. It's a bit like telling you the plot of a movie. So these days, I guess after our study, emergency department treatment doesn't really depend on size of the pneumothorax anymore. The symptoms have an effect, but I think it's really important that we understand that symptoms, you need to assess the symptoms after treatment has been given. Probably whether a pneumothorax is secondary or primary still affects how we treat a pneumothorax. So that probably still holds true, that we tend to put tubes in for secondary pneumothoraxes, but we are more likely to treat a primary pneumothorax conservatively. And sometimes recurrence is important. So we tend to treat recurrent pneumothoraxes with tubes. Although now I think we're more accepting of the fact that you don't have to put a tube in the ED. It might be that you just get them in for a VATS pleurodesis, so a surgical pleurodesis. But you don't have to rush to put a tube in the ED if you've got a good relationship with your surgeons and they can do a VATS procedure sooner rather than later. And the reason for this is, apart from the randomized controlled trial, we also did an observational study, and we know that size doesn't correlate with symptoms. And we do know that secondary pneumothoraxes aren't particularly well tolerated. So that's why we tend to often have to intervene. So when someone's got a reduced lung capacity, then they don't tolerate the pneumothorax as well, which is why we often see hypoxia in those secondary pneumothoraxes. And the big thing, of course, is this study, which you've all had a look at. And I'll say again that the questions you forwarded through Giorgio were fantastic questions, which showed that you actually had paid attention, which is great. And it's much better than me just telling you about the study, but having you guys read it and then think about it, I think is fantastic. It means we can, rather than focusing on the study, we can talk about the interpretation and how you see through an author's work. Remember that when we publish these papers, we try very hard to make it look like our papers are fantastic, and we try to hide the flaws. And this is what academics do. So this process of really pulling apart a study to work out where the flaws are, I think, is very important training for us as physicians. So this study was a collaboration between emergency medicine, respiratory medicine, thoracic surgery services across Australia and New Zealand. We had an international steering committee and a data safety and monitoring board to look at the safety of the study. We had seeding support or discretional funding from our unit. So we had resources paid for by the hospital that we were able to use for research that took our fancy. And we concentrated on this study because we thought it was so important. One of the things which we believed in our unit was that a lot of studies sponsored by drug companies weren't particularly good studies. We thought that what we really need to do was what we call medical reversal studies. And a medical reversal study is where you challenge the dogma. So you challenge the way you've been doing it for years and really try to dissect your practice and try and make it better. We eventually got funding, some startup grants, some national health funding from the National Health and Medical Research Council, and we were able to roll the study out to multiple sites. As you know, it was a multi-centre prospective randomised open-label blinded endpoint or probe non-inferiority study. I say that very quickly. The important thing to remember, and this is when you look at one of these studies, you've got to think about how the study was done. The really important things are that this was a pragmatic, a practical, a real-life comparison of two different ways of treating a pneumothorax, and it was based on intention to treat. I presume you guys are all familiar with the idea of intention to treat. What that means is you're picking a key point in your clinical pathway where you could go into two different branches and you randomize those two different branches. What actually happens after that kind of doesn't matter. You're looking at the impact of that key decision point on the natural behavior of the system and how patients turn out after that. So, and I'll come back to that later when I answer some of the questions that you all asked. It's also patient-centric, so it focuses on outcomes that are important to the patient, as well as the system, the efficiency and the cost. I think we need to do more studies like that. The great thing about studies like that is you don't need to have multiple $1 million to fund them and to develop drugs and placebos and all that. You're actually looking at randomizing and studying what we normally do to try and make our practice better. So this is my favourite kind of study. Georgia, am I making sense? Right, good. So our aim was to really see whether you could just do nothing, conservative management, and see if that's an effective therapeutic option. We hypothesised that pneumothoraxes would resolve over 8 weeks. The vast majority would resolve over 8 weeks. That with conservative treatment, we would have a similar or lower rate of pneumothorax recurrence because the defect in the lung would be given time to heal. We thought we would get a comparable or earlier return to work, and we hypothesised that it would be safe. So the primary outcome was lung re-expansion by 8 weeks. And the secondary ones, which I think were the most important ones, were pneumothorax recurrence, time to recovery, complications, how many patients crossed over to the other side of the arm, or other type of other treatment, and length of stay in hospital. And we enrolled what at the time we thought were large pneumothoraxes, so pneumothoraxes over 32%. Now, interestingly, I just did this today to make a point that they weren't small pneumothoraxes. So if you look at if you compare treatment groups, I don't know, is my mouse pointer coming up on the screen, Georgia? Yep. So this is the control group, this is the intervention group, and this is the size up to 100%. And you can see both groups had quite a few large pneumothoraxes. So we were looking at large pneumothoraxes, and often these patients in the control group had mediastinal deviation. And what a lot of people don't realise is that the deviation of the mediastinum to one side does not mean tension. It just means that the lung that's still attached to the pleura, its elasticity is dragging the mediastinum over. There's no tension on the other side. It's just that the collapse of the pleura allows the elastic recoil of the other lung to suck the pneumothorax, to suck the mediastinum over. It's not tension. Tension is I think it's a misconception. I don't think you can really get tension in a pneumothorax unless you positively pressure ventilate someone. I think the idea of a little flap letting air in and out is just rubbish, or what we call in Australia bullshit. I don't think it happens. And if you look over here, when we do a look at the size versus conversion to intervention. So these are the people that didn't convert from conservative to intervention, and these are the ones that did convert from conservative to intervention. You can see that size doesn't really matter. So you can see that there are a lot of small pneumothoraxes that for one reason or another were converted from conservative treatment to intervention. And so I'll come back to that a bit later, again, related to some of the questions that everyone's asked. The funny thing about studying in a major journal, publishing a study in a major journal is you start with all this information and the journal editors make you take it all out. They want to have this really short and succinct paper and all these really interesting things that you want to put aren't put there, and then the clinicians don't see it because the journal editors make you keep it down to 2,500 words and only 3 illustrations. It's important with any study, interpreting any study, to look at the exclusion criteria. So we had a number of exclusion criteria, and these were put in place from a safety point of view. When you're doing something like this for the first time, you've got to try and make it as safe as possible. So we made sure that it was a first pneumothorax, and I'll come back to why we did that in a sec. So we excluded a previous pneumothorax on the same side. You could have one on the other side, but not on that side. We excluded secondary pneumothoraxes, or coexistent hemothorax, or bilateral pneumothorax. We just didn't think that was safe. We excluded clinical instability that suggests a decompensated pneumothorax. I don't like the term tension because I don't think there's really tension, but I do call them decompensated pneumothorax. When the lung collapses, some people get a lot of pain, breathlessness, swinging intrathoracic pressure, reduced blood flow through the lung. They get hypoxic because they don't have a lung capacity, and they get decompensated. Usually what you see with these people is they get a drop in saturations and tachycardia, and it's not so much because of tension, it's because they've decompensated. So we use the word tension, but I try to use the word decompensated. We restricted ourselves to people between the age of 14 and 50 because we know from our previous work that over the age of 50 there was a high incidence of underlying secondary pneumothorax or underlying lung disease, and we thought from a safety point of view we'd like to exclude them for this study. Pregnancy, social circumstances, like any study like this, you need someone who's got good social circumstances so that you can do the follow-up. And we didn't want anyone who was going to go flying in the next 12 weeks. It's important because in Australian metropolitan areas we have a lot of the young men who smoke dope. They go, oh, the pressure goes up and they pop their pneumothorax. So we have a lot of young males who smoke dope who get pneumothoraxes. Within that population, they're often highly mobile. They might be what we call FIFO workers, fly in, fly out workers. So we had to make sure we weren't enrolling people that might need to fly out for a job in the next couple of weeks to a mine site. So that's why we excluded airplane travel in the next 12 weeks. And of course, if the patients declined. These you would have seen, the conservative treatment. We did a first assessment 90 minutes after randomization to see whether the patients had improved. And we had a structured treatment which included good analgesia. And this is very important because when a patient presents with pneumothorax and they have significant pain or breathlessness, often you find that if you give them good analgesia, they get less of the big thoracic pressure swings and they settle down and they look better. And they don't drop their saturations. If they have, you can function on one normal lung. And a lot of people don't remember that many years ago, the treatment for tuberculosis was to deliberately collapse the lung or to rest the lung. And so people would be functioning quite well with one completely collapsed lung. So if you give people analgesia and if they have normal underlying lungs, even with a complete pneumothorax, they often are much better after a few hours of observation. We did another assessment at 4 hours after randomization and repeated the chest X-ray. In retrospect, we thought we didn't need to do that chest X-ray because even if we saw a larger pneumothorax, if the patient was stable, we'd keep on treating them conservatively. But it was just interesting. It was part of the study protocol because we thought we had to do a lot of observations to back up our decision making. And then one of the most important things before discharge is that we take them off oxygen and you walk them around the observation ward to make sure they can do their activities of daily living. There's no point sending a patient home for conservative management if they walk 10 steps, get hypoxic and collapse. So you've got to do a functional assessment and make sure they're fine without oxygen. Once you let them settle down and given them analgesia, and make sure they can function okay before they go home. We had some criteria there, respiratory rate greater than 30, a drop in blood pressure, SATs less than 90% on room air, or a heart rate greater than a blood pressure. And you might be aware of this, it's called the shock index. Basically, if the heart rate goes high and the blood pressure goes low, you get a heart rate greater than a systolic blood pressure. That was one of our indications for intervention, or intolerable symptoms. Now, I think I saw one patient do this, and they did it very quickly after presentation. If we see a trend in observations, or if they're unable to walk, then we consider switch to interventional treatment, or sometimes we just observe people overnight. And often what we found is that when you see someone with a large pneumothorax and deviation of the mediastinum, everyone's too frightened to send them home. And so we would often put these people into our emergency observation ward overnight and assess them the next morning before they go home. Interventional treatment, we used a small bore Seldinger style device, and there's a bit of history behind that. We thought about doing needle aspiration early on, but one of the important things with a study like this is to try and get a really good protocol. So we went through a pilot phase where we engaged with clinicians. And we had 5 or 6 emergency departments in Western Australia where we all got together, talked to the clinicians. We actually tried the protocol a few times. And the feedback we got was, look, no one actually does needle aspiration anymore. We're too busy to sit there with a needle and a 3-way tap going. You can sit there for an hour doing a needle aspiration and not get anywhere. So what people were doing was these nice new soft bore Seldinger. The Seldinger, you use that term Seldinger for the catheters. Yeah, so with these nice small bore 12 French Seldinger catheters, they're very comfortable for patients. The local anesthetic, just pop one in, and you just leave it attached to a little underwater drain or a Heimlich type valve. Patient moves around, and it just, you get drainage over about an hour. So rather than doing aspiration, we would just pop that drain in, make sure it was bubbling, get the patient to take a few breaths, and and the pneumothorax would gradually inflate. After an hour, we'd do a repeat chest X-ray, and then we would consider clamping the device. Now, the reason we clamp that is because it's basically simulated an aspiration. You clamp it, then you watch them for another 4 hours, and if the pneumothorax hasn't reaccumulated, you've effectively done an aspiration, and you've tested the fact that the lung stays up, and then you can pull the catheter out and send them home. But if they haven't settled or it's reaccumulated, rather than doing another procedure, so if you did a needle aspiration, you would then have to go and do another chest procedure. We've done one procedure, put the catheter in, and if after an hour with a 3-way tap turned off, the pneumothorax comes up, just turn the tap open, admit them to the ward, and they have ongoing drainage. Just one procedure for the patient. So this was done, we chose this after a lot of collaboration with clinicians, and they really wanted us to do this because it was one procedure, easy to manage, better comfort for the patient. Does that, any questions around that part? Does that make sense? Yep. Now, if the patient didn't respond, we would continue drainage with an underwater seal drain. We wouldn't apply suction. We're generally against using suction, and it would admit them to hospital. And then further management was at the discretion of the treating team. So at this point, we would hand over from emergency medicine to respiratory medicine or thoracic surgery, depending on the unit. Usually it's a respiratory physician, a respiratory medicine team would look after them after this period of time. And we didn't prescribe the treatment. We just asked that people, because everyone in Australia follows the BTS guidelines, that's the British Thoracic Society guidelines. So there was more or less standardised approach because everyone was a member of the same college and tended to follow those guidelines in Australia. Now, the primary outcome was no difference between groups. So at 8 weeks, there was no significant difference in resolution rates. The majority had resolved in both groups. But the secondary outcomes are really important, and I know you guys have gone through these. So I look at these numbers. You know, you don't want to ask the author of a study what did you know that if you ask an author of a study what the results of their study were, they often give you the wrong answer because they haven't gone back to look at it because they're tired of looking at it and they can't remember. But I'll make an effort not to tell you inaccurate information. But I'll just show you the slide, and you've all looked at this. So if you look at the procedures, not surprisingly, an interventional group, 94% had procedures versus 15% in the conservative group. And I'll come back to that in a sec. That's an important point, that some of the people in the interventional arm didn't have intervention. If you go in, again, intending to drain, it leads to more drainage. So 51% of people had chest drains for more than 72 hours in the interventional group. But in the conservative group, only 9.3% had prolonged chest drainage. Suction was more often used in the interventional group. There was more CT scans, there were more hospital revisits, there were more adverse events, there were more serious adverse events, there was more recurrence of the pneumothorax, there are more surgical procedures, and the length of stay was longer. So all of those really important cost and patient-focused outcomes were worse in the interventional group. And I think that's, so the secondary outcomes are the most important part of this study. So in a nutshell, clinicians love doing things. Have you ever tried to tell a surgeon that they shouldn't operate? Orthopedic surgeons love to do things to shoulders and knees and backs and spines. And when you do a trial, they often don't like the results. And this is another one of those cases. Clinicians love to do interventions. Device manufacturers love you to do interventions, and they'll fund you lots of very expensive lunches and dinners while they tell you about their new devices because they love that you do it. But conservative management is best for patients and the healthcare system, so not doing procedures. Or trying to. Remember, sir, doesn't mean not everyone, but trying to do no procedures. Patients and clinicians do opt out and pursue interventional management, but do pursue intervention in about 15% of cases. And I think it's important, though, in a nutshell, don't forget the analgesia and observation. If you do this, you've got to give the patient good analgesia. You have to observe them for a period of time to make sure that they're stable. You need an excellent follow-up system. You need your respiratory and thoracic or thoracic physicians to be on board. You want early outpatient review. You want patient reassurance and support. You don't want warfare between specialties in front of the patient. You don't want them turning up to a respiratory physician who says, oh, what are those hopeless emergency doctors doing? You all want to be on the same page, understand the evidence, and provide good care as a team. And don't forget that our study used exclusion criteria to manage risk. Now, the results are probably generalizable to other people without all those exclusion criteria, but that hasn't been confirmed yet. We really need to do some longer term studies of this approach in real life with patients that don't have all those exclusion criteria, I think. I haven't done that because I've done too many randomized controlled trials and I can't do any more. It's too exhausting. I'm hoping someone else will. Over to you guys. Interestingly, and this has been happening with the work I do now, there's a move also to treat many traumatic pneumothoraxes conservatively. I've done this a number of times in the last year. Even when we're flying in our aeromedical unit, we'll do an ultrasound in the scene. We'll see a pneumothorax, but we won't intervene. We'll just fly them. Even though we're going up and dropping pressure, we'll manage them without chest drain insertion. Now, that's another story. I think I'm not saying that this study justifies that, but it's just an interesting thing that there are some follow-on effects, and I think you will see more about conservative management moving forward. Recently, we've had some penetrating cardiac injuries that we're managing conservatively too. Go figure that. Anyway, I digress a little bit. So, can I answer all your questions? I hope that we will answer your questions, and I'll bring up the questions and try and go through them now. That's my border collie dog, by the way. She's a very cute dog, very inquisitive, if anyone's interested. So, study design. Now, we asked why was 9% chosen as a non-inferiority margin? Well, it was a consensus, which means consensus is a really scientific way of saying we guessed. We thought that clinicians would want to see at least a 1 in 10 chance of equivalent outcomes. People often say that, well, I'll accept kind of like 90%. So it's based upon how people tend to approach it. 1 in 10 is kind of acceptable if you're out a little bit, as long as there are other reasons for justifying it. And also, this is really important, it fitted with what we thought would be an achievable recruitment target. There's no point going for a 3% non-inferiority margin if it would take us 20 years. So we realistically could only do this. We didn't, as it was, we only just managed to get our numbers up. It was a really hard study to do and to maintain. Next question, the trial was on patients with first pneumothorax. Would you do it differently in non-first pneumothorax? So any difference between first versus second pneumothoraxes? Well, the reason we did it this way was because one of our hypotheses was that conservative management would reduce the incidence of recurrence. So we wanted to study virgin lungs, no previous pneumothoraxes, because we wanted to see if that first treatment might have a profound impact over the long term. And one of the theories was that if you suck out the air and keep the lung exposed, then you won't get really good healing of that defect because you're continually pulling air out of it. And often you drain these patients for 5, 10, 14 days, just continually pulling air out of the defect. So we wanted to see whether there was a really big difference looking at virginal, the sort of undamaged lungs. Now, it's probably applicable to recurrent pneumothoraxes, but if they're minimally symptomatic after analgesia, but we tend to think about pleurodesis, VATS pleurodesis. So they're not really the same. Once you've got a recurrent pneumothorax, there's more chance that you want the surgeons to be involved to have a look. There's often an underlying bleb that can be treated, for example. What was the most difficult thing in the organisation of the trial? Well, there were several things. It was really hard to get site consensus and buy-in to the study. And then when I say consensus, I mean everyone being happy with the protocol. Because, we had one hospital that said, this is an unethical study. You can't not treat patients. It's not ethical. We know that treatment is better. We call that site A. Site B would say, this is not ethical. You can't go putting tubes into people. We know that these people don't need tubes. And so we had to bring together these really diverse opinions and convince them that this diversity was actually the reason why we needed to do the study. And they go, oh, all right, then I guess I can cope with that. So we had to do a lot of consensus building. We needed to have committed local champions. I can't spell collaboration either. Anyway, collaborations with regional investigators. And we would often recruit for other studies. So I would say to one person, look, hey, can you help us with this study? And we'll help you with your study. So it was a kind of a mutually beneficial arrangement to help each other, because this is a very constrained, or in Australia, medical research is a very constrained funding environment. We don't have a lot of funds. So you're really relying on goodwill and helping each other out. So if you help someone do their study, they'll help you do your study. And so we established a good research network with some young, enthusiastic researchers. I was young once before I lost all my hair because this study got me very, very tired. The other problem was maintaining awareness for an uncommon presentation. Probably there's only one first pneumothorax per 4,000 ED presentations, so that's not a lot of pneumothoraxes. And our solution to that was working on a variety of recruitment triggers. That was quite hard work and not always successful. But then it came back down to having those really engaged investigators who wanted to do the study, and they'd remind people. So recruitment triggers mean that, so for example, when we did our antivenom studies, you couldn't go and grab the antivenom without a big sign saying, you've got to enroll them in a study. In this case, wherever the catheters were, there's a big sign saying, you've got to enroll them in the study. So there's a little trigger at a point where everyone has to go before treating a patient like this. So you've got to work out, how do I remind people to do this study? What are the key points? And making sure that the respiratory people knew. So when they got a call from the ED, they'd say, have you considered doing the study? So there are little points where we could make sure we reminded staff. Some staff were only in the ED for 3 months. They might only see one pneumothorax the whole time they were there before they rotate to another job. So you have to have these triggers. The other problem was infrastructure for timely follow-up. It's very hard to do follow-up for these cases when you're recruiting over 3 states, 2 countries, departments that are often small and don't have resources. So we had an electronic randomization and monitoring system, and it would send a note to the regional coordinator. So we'd have a coordinator for each cluster of hospitals. They get an email and an SMS from the randomization database as soon as the case was enrolled, and they would know to chase up, do the 24-hour follow-up and make sure we didn't lose patients. Next question. Why did you consider as reference standard the thoracic X-ray read and by the ED physician, not by the radiologist? Well, two reasons. One reason, the reason is that radiologists aren't in our hospitals 24 hours. We do have 24-hour radiologists reading CT scans, but they often take 2 days to read a chest X-ray. It's basically the ED physician's job in this country to read the chest X-rays. However, you might have missed that we did, though, get 2 radiologists to read all the X-rays for the final analysis, and we had 2 sort of read every single X-ray to make sure the data was good, and there was a high level of correlation anyway. So that was our little quality control bit. Next question: how did you choose the 4 hours cutoff to discharge? Do you think it could be less or more according to the patient, and which variables would you consider? We chose 4 hours because that's the maximum length of stay. LOS is length of stay in our EDs. You've probably heard of the 4-hour rule, where there was a big push at that time to get patients out of the ED within 4 hours. The patients often stayed longer, as I mentioned before, overnight in the ED observation ward, especially those with large pneumothoraxes. Do I think it could be less or more? I don't know. 4 hours worked quite well. It fitted with it did used to fit with the way the ED functions. In 4 hours, you're likely to get at least 3 or 4 sets of observations, so you can look at a trend. You know, if they're a large pneumothorax or if the patient was particularly symptomatic, we would extend the observation period. Is it normal do you all have observation wards where you can put people outside the ED? Yeah, so you'd be able to do the same kind of thing. It does rely on having good nursing staff. We've found over the years, emergency medicine has grown quite a bit in Australia. We used to put very well people in observation wards, but we find now with better equipment and more experienced nurses, we can put quite sick patients. We can have patients on adrenaline infusions and post anti-venom, severe toxidrones in our observation wards now, because the nursing staff in some hospitals are getting quite experienced. So you can do this in a good observation ward where the nurses know what to look for. Another question: why did patients in the non-intervention group have an intervention? Who were they? Who were the most critical patients? Now, we provided through the New England Journal of Medicine website an online supplement, which I'll show on the next slide. My personal observation was that patient-clinician preconceptions and preference, and maybe a misunderstanding of mediastinal deviation on the chest X-ray played a big role in this. And as I showed you before, a lot of the patients who crossed over had quite small pneumothoraxes. And it's also worth noting that in the intervention group, 10 patients refused to have intervention. They said, no, I don't want that. So, you have people actually pulling out of intervention as well. And that's the nature of these intention to treat studies. Who were the most critical patients? I think what I'd say in response to that is, one thing we noticed both in this study and a previous observational study is that patients who are going to do badly are obvious almost the moment they walk in the door. This is a bit different to a traumatic pneumothorax. Traumatic pneumothoraxes often develop over time, particularly when you do intermittent positive pressure ventilation. As the pneumothorax gets bigger and patient gets sicker, hypovolemic, increasing size, etc. However, these guys often, the ones who get hypoxic have an abnormal underlying lung or reduced lung capacity, so that they don't cope with the pneumothorax, and they tend to get hypoxic very early. So you tend to see this pretty quickly if they're going to be critical, if they're going to not tolerate conservative treatment. Did patients in the non-intervention group have more adverse events? No, they didn't. If you look at the study outcomes, all the adverse events occurred in the intervention group. The ones who crossed over, it was only a small, I couldn't say whether the patients who crossed over and had an intervention had less or more problems compared to the ones who went straight to intervention, because the numbers weren't that high. But we didn't see an obvious difference, but I wouldn't say there's not a high level of confidence in that. Was it the physician in charge who decided it? Yes. Although sometimes they called a chief investigator to discuss it. So we were sometimes we were always available to talk to the clinicians if they wanted to talk to us. Can this be a problem for generalizability and safeness of the results? No, because that's the point of the intention to treat trial. An intention to treat study, it's deliberately designed to say, you just got to make the decision here, now what happens in real life? And we just want to see what happened in real life. So I think people having different approaches to problems just reflects how clinicians are going to behave normally. So I think it actually adds to the strength of the study, if that makes sense. These are the reasons for conversion. As I showed before, there weren't big differences in size, but abnormal physiological observations, intolerable symptoms. Often patients would just find the pain was quite severe, and that's got no relation to pneumothorax size. Often patients with complete pneumothoraxes have no symptoms at all. Difficulty mobilizing during the walk test. Increasing size of the pneumothorax was a reason people did it. I'm not saying it's the right thing to do, because we know that pneumothoraxes will start small and get big. But when you've done a series of x-rays and the clinician sees the pneumothorax getting bigger, it doesn't matter whether it's logical or not, they will tend to intervene because of that, rightly or wrongly. We saw hemothoraxes in a couple of people, and patient anxiety and slow resolution were the reasons. Some patients had a tube inserted while others had aspiration. Is there any evidence that one of the two options is better? What would you suggest as the alternative standard of care? The only reason that some people had aspiration is because early on there were some people who just did things a bit differently, and very early on there wasn't, probably in the first 10 patients or so, a few people sort of did slightly different things like aspiration rather than using the tube. Other studies suggest that needle aspiration is okay for symptomatic large pneumothoraxes. You can get 2.5 litres of air. It's said to be less painful, but it is time consuming, risks failure, and then you have to do another procedure, as I mentioned before. Chest tube insertion is most popular in our practices. Selding a small bore, very comfortable. You may have to then go and put a larger ICC in, but usually you don't. So our preference of these options, as I mentioned before, is to use these soft Selding 12 French tubes. Did the aspiration group have a different prognosis? Unable to assess because of the study design and numbers. We only had a few people had aspiration versus the 12 French put in. But 92% started with a 12 French Seldinger rather than aspiration. So the mean length is the next question. So talking about clarifying the results. The mean length of stay in the non-invasive group was less than the invasive group. Also, the length of stay of the patients of the non-invasive group was less or equal to the other, or was it because most patients were not hospitalized? Hang on, I understood this before, sorry.
Maybe we mean if, because for sure the intervention group, most of the intervention group will be admitted in the hospital, while
That's right.
most of the, and so if you calculate the length of stay, but if you calculate the length of stay on all the people admitted and discharged once, of course the length of stay will be less. Did you calculate the length of stay in the patient, or only patient admitted to the hospital, or also considering patient discharged to the hospital?
No, length of stay was based from the moment of entering the ED to the moment leaving the hospital. So it would include ED stay and hospital. And I think the answer is that the result was basically a result of the study, because once you stick a tube in the pleural space, we don't send people home. So it was a natural outcome was to stay in a hospital longer with a tube in. So yes, we didn't have the option of treatment at home with a tube in at that time. So the greater length of stay reflected the intervention. It is interesting though, one thing we saw with intervention was that whereas in the conservative group, so many people were just fine. They had a pneumothorax that would last for weeks and gradually resolve. Yet some people, when you put the tube in, often they would be bubbling for sometimes 5, 6, 7, 8, 10 days. It's like when you put a tube in, not only are you saying, yes, you've got to go into hospital because the tube's in, but they would stay in for a long period of time, because you don't give the lung a chance to heal and then re-expand. if that makes sense. So putting the results in context again, is the watchful waiting in pneumothorax now the standard of care in Australia and New Zealand? The answer to that is it depends. I suppose yes for most of the participating sites, but otherwise I'm not sure it needs more study. One of the reasons that I like to say these trials are fantastic, not only are they relatively cheap when you compare two existing treatment approaches, but they introduce a new concept to staff. And what the trial did do is it got people comfortable with a conservative approach, so that it's now people are more likely to use conservative treatment. But I don't know if that's been sustained because staff have changed over the last few years since the study. It would be interesting to go back and see how much this has taken. And I haven't done any further research to look at that. Clearly, I like to treat them conservatively, but I don't know about everyone else. The revised BTS, British Thoracic Society guidelines, there's a draft that went out for consultation last year, and it should be coming out this month or next month. They now, so this is an international guideline through most English-speaking countries. The Americans have their own, but I think, Australia, New Zealand, Britain, and I think some Canadians, but they're fairly well accepted internationally amongst some countries, approximating 5% of the global population. Now accept conservative management of pneumothorax of any size, which is a big change to previous guidelines. Although they say as long as symptoms are minimal. I think they might have missed the point that the period of observation and analgesia is really important before you make that assessment. So I haven't seen the final guidelines, but the early draft didn't seem to appreciate the importance of observation and analgesia. But they did say that size of the pneumothorax doesn't matter. That's all about symptoms and stability. What is this? This is a study we did before, and I just want to make the point here that when you compare people with primaries versus secondary pneumothorax, the secondary pneumothoraxes tend to be older, primaries younger. The younger ones tend to be male, and we have in the past had a long association with smoking, including marijuana as well as cigarettes. So that sort of tells you about the two different groups. The saturations in the spontaneous pneumothorax or secondary pneumothorax, you see 20% are hypoxic on arrival versus 2% of the primaries. So this is just backs up some of the information that I was giving you before, that often they're hypoxic very early on. If they've got underlying lung disease, and that's part of the physiological instability, they tend to have a higher respiratory rate, a higher heart rate. Why did I bring that up? Oh yeah, this is the watching and waiting, looking at whether we do conservative management. So just to re-emphasize the fact that you often will work out early on whether someone's going to cope, and often it's underlying lung disease is the thing to look out for before you try conservative management. I did these this afternoon. My apologies if it doesn't quite make sense. Yeah, I'm just saying this. Sorry, I'm just saying the same thing in this slide that I showed you on the previous slide, so I'll move on. Now, putting the results in context, our next question, do you think that it is mandatory to do such a large number of thoracic x-rays? No, I don't. We just did that as part of the study protocol. Do you think that some x-rays could be avoided and trust the clinical picture of the patient? Yes, I do. When would you suggest to do the chest x-ray? I would say if there are persistent or worsening clinical symptoms and signs, and probably around 8 weeks to document resolution. So you want to document the resolution before they say go flying or whatever. Is oxygen in non-hypoxic patients useful? I think probably not, and there's a couple of reasons. One is it takes a long time and it just dries up the mouth. If you're giving high flow oxygen to try and really get the nitrogen, or to denitrogenize the pneumothorax, it takes a long time. It's high concentration, very drying and uncomfortable. And the other thing is that it takes time for a leak to heal. So you may get whether you're doing this with oxygen or whether you're doing it with a tube, I mean, what's happening is the lungs are going to take a while to heal and reinflate. So oxygen, I say, is a bit like a broken pencil, pointless. Joke. This is the problem, the evil monologue. I can't hear people laughing or scowling. Now, talking about this issue of, I wonder why I brought this up. I guess, excuse me for a sec. I wanted to just throw another thing in, so take a bit of a break. Are there any questions at this stage, Giorgio, before I talk about a couple of other little things?
Is there any question? Maybe a question that someone of us would like to ask is if you use, not in the study, because I think it's very difficult in the study to use ultrasound as reference standard, but do you use ultrasound for pneumothorax diagnosis or not, or do you think is an option?
Possibly, but you can't really see the size. We certainly use ultrasounds pre-hospital in a trauma setting, in the acute trauma resuscitation. But that's more, but even then, I sometimes have my doubts because we will see a pneumothorax, and if the patient is not compromised, we often won't do anything about it anyway. Yeah, no, I think I probably do it. I'd still rely on a chest X-ray to get an idea of the size. And also it assesses underlying lung disease as well, possibly a little bit better. So this is one of the online supplements, and I've been talking a bit about resolution of the pneumothorax. One of the interesting things is this is the probability of recurrence, so probability of no recurrence. So here we go in the conservative treatment. These patients basically are not having a recurrence, or they're having a recurrence gradually, and eventually get to about 10% of people having recurrences. There's not much in the long term. The interventional group, probably you can see that at tracks there's less recurrences, but you see the same direction as time goes on. So earlier on, you get all these recurrences in the interventional group, but then you track the same number over time. I don't think this means that recurrence rates are different between the two groups, because I think over time you're getting the same incidence of recurrences later on. But early on, this divergence here, I don't think this is a recurrence. I think it's the underlying disease. I think that basically the lung takes a month or two to heal. And what's happening here is we diagnose a recurrence because the pneumothorax has come back, but actually it was always going to keep leaking because it hasn't really healed yet. Once you get to the point where they're both healed, you've got the same rate. So up here, you've almost got these are like false diagnoses of recurrence. We statistically treat them as a recurrence, but what's happening is the lung has simply popped open again because the defect hasn't healed. But then once the defect is healed, you've got the same recurrence rate in both groups, is what I think is happening there. And you can see here the very low rate, because we actually, even here, we would wait. We wouldn't diagnose a recurrence unless we had at least one chest X-ray showing no pneumothorax before it came back. If you compare that with this study here, which is a Chen study in Lancet 2013, they had this phenomenal recurrence rate of close to like 50%. And so when they used minocycline pleurodesis, they reduced it to 30%. And yet our baseline recurrence rate was 10%. When you look at the way they did the study, they were looking at recurrences like within hours or within, a day or so of doing the initial treatment. So I think a lot of the time was really clouded by the fact that the pneumothorax, the lung defect hadn't had a chance to heal. So it is, when you look at these studies, it's fascinating to look at the differences in how people define recurrence. So putting the results in context, this is another question. The reduction in adverse events and the reduction in hospital stay were secondary endpoints. Do you think they should be considered clinically meaningful? Yes. So yeah, I think the secondary endpoints were the most important outcomes for the study. But the reason we chose the primary outcome is we had to get a research grant, and research grant reviewers hate anything apart from our objective dichotomous outcome. And because it was an open label study, we need to have something as objective as possible. So this is the only objective primary outcome we could think of, but I actually don't think it was the most important outcome. Why did we choose 8 weeks for the primary endpoint? I've put this in. No one actually asked this question, but I often get asked that. We know that between 1 and 2% of the volume of the hemothorax, is reduced every 24 hours. So a complete pneumothorax could take up to 6 weeks to resolve spontaneously. Stradling and Poole back in 1966 did an observational study looking at simple pneumothoraxes, a large number that weren't intervened, or sorry, they had 88 had conservative treatment, 10 had aspiration, 8 had intercostal catheters, and they saw a recurrence rate similar to ours, about 11% over 6 years. But they also found that it was about 6 weeks. Round about 6 weeks was when most of them resolved. So we just chose 8 weeks because it was a bit longer, and it actually fitted with how our clinics would work. One more question that was in there. Is there any other therapy other than the invasive one that can be useful in pneumothorax? Well, the first one was, this is a study published in, 2020 by Halifax and others, looking at ambulatory management. And I bring this up because one of the reasons, one of the critiques of our study was, well, look, you said there was a longer length of stay in your intervention group. That's because you didn't send them home with the tubes in. And so here's this study saying you can send people home with tubes in their chest. But it is at the expense of increased adverse events. So I'm not sure how this really fits in. I think where you do have to put a tube in, if you've got good ambulatory care processes, I don't see why you couldn't send someone home with this. So I think this is something to add to our list of things we can do if you have the system set up to do it. So I think we should still try not to intervene. But if we find that we do intervene, I think this is a valid option if you've got the right systems of care in place. And I bring this study up. I showed you this before. There is early pleurodesis. I don't think we've got any evidence to really support that in our setting, because this study I find problematic because of the very high recurrence rates. I find that hard to explain. I think they had a lot of smokers, whether they had some unusual degrees of lung disease in that group, or whether it was the way they defined the recurrence, as I mentioned before. So minocycline pleurodesis is not commonly used here, but we do have some very, do you guys have a lot of VATS, the video-assisted thoracic surgery pleurodesis? Is that something which is taking off over there in Italy? Yeah.
Well, probably we don't see, just not in the acute setting. Probably they are sent to thoracic surgeon, and then they evaluate it, and sometimes not the first time, but.
Yeah, so I mean, that's the only other thing that's worth raising, but I don't think that it's something, it would really, I'd only refer people for that in my practice when I've got someone who's come with a recurrent pneumothorax. So, but that's just another treatment option. And I guess that's it. So they were great questions, and hopefully it made a bit of sense, and you can see a little bit more behind the study and how much fun it was. And my evil monologue is now completed, so if there are any other questions, I'll be happy to take them.
Is there any other? Thank you very much. Of course, Simon. I think it was very, very interesting, and I think that it's very nice to do some question before, and is a good, because we had some other presentation but without question. I think that is a good model. This maybe SG before raised hand, but I don't know if it was she or he wanted to say, Simona Gombia maybe wanted to say something, or maybe she just did something wrong.
Accidentally clicked.
Yes. Is there any question? Okay, so I think that we had done all our questions before, so this is very important. And so thank you so much for being here with us and for the presentation and all the things that you said. And the last question is, are you happy to having come back in Tasmania and go to helicopter, or do you miss your academic work and emergency department? Do you still work also in the emergency department, or just
I do,
Yes.
yeah. I still do some work as an emergency physician in the hospital, but most of my time has been spent setting up the new helicopter service, so it's been a fair bit of work. But I do miss my research. But you know, I found that after doing 10 years of academic work, it changed from being enjoyable doing studies I was interested in to then having a team that I had to find salaries for. And so I was spending more than half of my time trying to get research grants for studies I didn't care about. And it became really frustrating after a while, and I thought it's time to move on. So I really enjoyed the academic work, but I find the pursuit of grant money to be exhausting. So yeah, well, it was time to move on. I am getting a little bit tired of swinging around in helicopters, though. I get a sore back and neck sitting in them. They're very small, and I think it's time to go back to clinical work again. I mean, when I say clinical, it's clinical work, but I mean back to the ED, because at least you can stand up straight in the ED.
Thank you so much, Simon. Thank you very much. And
Pleasure.
hope to see you again, maybe to anaphylaxis, or it depends on you. And if you come in Italy, you will be our host. Okay.
That'd be great.
Thank you
All
very
right, thanks
much.
for having me. And nice to not see you all. All I can see is round dots. But yes, thanks for your attention, and maybe see you next time.
Thank you.
Bye.
Thank you very much.
Bye.
Thank you
Pleasure.
very much.